L-carnitine. So thank you for the golden opportunities. So I apologize for rushing through since it's a time-bound CME, so I'm not able to complete properly. Thank you.
Thank you, Sir Unavel. The one thing's in the injury. So higher antibiotic covering all like penum antibiotic as well as quinolones and metrogyl. And after that he can stop metrogyl. That's antibiotic management is very important. Fluid management is very important. And if you diagnose early acute kidney injury, volume overload has to be avoided. And early phase, that is fluid challenge is very important for pre-renal azotemia. And multiple fasciotomy. If nowadays early plasma paresis works out very well. And in neurotoxic poisoning, early intubation, early weaning. That's a point I want to mention. And scorpion stench, two things very important. Always prazosin. Prazosin is a drug of choice. And dopamine is the drug of choice. Dopamine is contraindicated. That point I want to mention. So even small scorpion sting, give early as possible prazosin. Even 90/60 BP also give prazosin. That is the only antidote. Sometimes BP pulse, BP chorea, autonomic storm. Both hypertension, hypotension more common. Hypertension and tachyarrhythmia, bradyarrhythmia both common. So prazosin is a drug of choice. Thank you very much.
Thank you, sir.
Any other question from the audience?
Now we are using NGEL, neutrophil associated gelatinase lipocarpine. It is a biomarker which can be used in the emergency room. We can predict whether this patient needs renal replacement therapy or this patient is going for renal failure, acute kidney injury, so that we can prevent further nephrotoxic insult can be done, so that it will be helpful in the fast recovery. And moreover, regarding the prazosin, there is a fear among the physician in the rural area that blood pressure is 90/60 or 100/60, whether I need to give prazosin or not. So even the blood pressure, as Dr. Palnipan quoted, even it is very low, we can give, but only one thing, the patient should not be in the hypovolemia. So hydrate the patient well and start prazosin. So that will help you landing the patient from ICU. Thank you.
Thank you, sir, for such a wonderful presentation. Now I request the chairpersons of this session, Dr. V. Palaniappan, sir.
So really, thank you, sir. It was a wonderful lecture. And now I am very happy to see our undergraduates to be house surgeons. So one small thing I would like to add is, we don't go for test dose for ASV, because people used to do, but now it is really, it's abandoned. Don't go for test dose because of two reasons. One is the test dose is going to elicit an immune response, so the subsequent dose is going to be more harmful. Second is, the ASV-induced anaphylaxis is not mediated by IgE, it is mediated by complement. So it is of no use. Even though the patient may not respond, react to your test dose, he may react to your original dose. So please don't go for test dose for ASV. You can go directly, but start slowly, and then you gradually increase it. That's a very important thing which I want to highlight. Second is, as Sir pointed out, the essential difference between dopamine and dobutamine is dopamine doesn't decrease the pulmonary capillary wedge pressure, the so-called PCWP, but dobutamine does it. So we want our pulmonary capillary wedge pressure to be decreased in this non-cardiogenic pulmonary edema. So that is the reason why dobutamine is prepared than dopamine. So that's what I wanted to add. Thank you, sir. Thank you.
Thank you.
Thank you, sir, for your valuable information.
Thank you, sir.
Now I request the chairpersons of this session, Dr. V. Palaniappan, sir, and Dr. S. Senthilkumaran, sir, to felicitate the speaker, Dr. A. Sharavanavel.
Thank you, sirs. I now request Dr. A. Saravanavel, sir, to kindly join the audience. Tick, tick, tick. When that regular rhythm goes off, that's exactly the point where things go haywire. To talk more on the topic arrhythmia management, I now call upon Dr. K. Muralidharan. He's a senior consultant in emergency medicine and medico-legal consultant. Over to you, sir.
Good morning, everybody. Nice to see everybody in fresh faces after the 2 lectures. Actually, arrhythmia is always a chaotic and confusing one for every day when you see a patient in your emergency department. But only thing is, try to identify the rhythm, then you can able to go for the management. So since it is a shorter period, I like to go with some identification also, as well as along with the management, so that I have a very emergency view of the arrhythmia. Okay. Nice. Yeah, thank you. Yeah, before going into the further management, just as a picture showing the conduction system of heart, which everybody knows very well, and the ECG strips about the PQRS, ST, PR, and all other things, the same thing. Okay, actually today we will go into the steps. One is whether to look whether there is a QRS, next whether there is a P wave, and what is the relationship between the P wave and the QRS, then ultimately the management of some of the arrhythmias. Okay, coming to the heart block. So first you have to look for the number of P is equal to number of QRS. Whenever you see ECG them, you have to check for it. If it is yes, then you need to look out for the PR interval. If the PR interval is less than 0.2 second, then it is a normal. If the PR interval is more than 0.2 seconds, then we take it as a first degree AV block. Then if the number of P and number of QRS is not equal, then go for the RR interval. If the RR interval is constant, then it is a complete heart block, that is the third degree AV block, which we will see in the further slides. And if the RR interval is not constant, then go for the PR interval. If the PR interval is constant, then it is a second degree type 2 block. Then if the PR interval is not constant, then it's a type 1 second degree, that is the Wenke-Bach phenomenon. So this is a picture showing QRS. We are going to say QRS, which all 4 rhythms are important. They are all arrest rhythms. So QRS, it is yes, then if it is narrow, then it is a pulsar statical activity. I already mentioned these are all 4 arrest rhythms. If it is wide, it is a ventricular tachycardia. If there is no QRS at all, it is a confusing, chaotic rhythm, then it is an ventricular fibrillation, and everybody well know there is a flat line, that is a asystole. Okay. So coming to the next one, is there a P wave? Yes, no. If it is no, then go for the RR interval. Look for the RR interval. If the RR interval is varying, then it is atrial fibrillation. If the RR interval constant and the absence of P wave, then it may be a junctional rhythm. Okay. So if there is a P wave, then go for the rate. If the rate is more than 220 to 350, then it is an atrial flutter, where the waves will be in a sawtooth appearance that we'll see later. Okay. Again, if the PF is there, if the morphology, look for the morphology, again whether it is inverted, then again it is a junctional. Either inverted or absence of PV, we call it as a junctional rhythm. Okay. This is some few 3 slides which we always have a confusion, like what is the pre-excitatory, excitatory mechanism, what is the re-entrant tachycardias, especially in PSVT and PNRVT. So this is a mechanism behind that. So whenever an arrhythmia is triggered, it's triggered by a premature beat. So there are 2 conducting pathways. One is the fast conducting pathway and the other is the slow conducting pathway. The fast conducting pathway is blocked because the long refractory period, whereas the slow conduction have a the slow conduction pathway has a fast recovery period. So long refractory period, so the beat can only go down to the slow conducting. There is a block in the fast conducting path. So the wave of excitation from the premature beat arrives at the base, that is the distal end of the fast conducting pathway. Thereby again it's recovered and goes back, retrograde, travels retrograde to the fast pathway. So this cycle continues. On arriving the top fast pathway, it finds the slow pathway and recovered, and therefore the wave of excitation re-enters and the cycle keep on rotating. With this triggers the re-entry circuit, which causing the PSVT things. Okay. So this is a rhythm. Can anybody can tell? This is a, don't see the rate because it may be confusing, but this is a typical sawtooth appearance of, you can see there. This is an atrial flutter. What about this rhythm? There is a varying RR interval which goes for atrial fibrillation. This is nothing but a sinus bradycardia. Here you can see a gradual prolongation of the PR interval followed by a dropped beat. Gradual prolongation of the PR interval followed by a dropped beat. What is it? It's a second degree type 1. Okay, that is Mobitz type 1 heart block. This is a rhythm showing the P wave comes on its own and the QRS comes on its own. There is no relationship between the P and the QRS. The atrium is conducting on its own and the ventricle is conducting on its own. So it's a complete AV nodal block. That is the third degree heart block. Can you appreciate this rhythm? It is a wide complex rhythm with varying morphology. There is no P. There is only a QRS with varying morphology. It's a polymorphic VT, otherwise we call it as torsady pointing. So coming to the management of the narrow complex arrhythmias, first and foremost we come across the most common is the supraventricular tachycardia. If it is stable, then go for your vagal maneuvers unless otherwise it's contraindicated. Then the drug of choice always, it's an adenosine. Adenosine should be given in a rapid bolus since it has got a very low plasma half-life time. So it has to be injected very rapidly. Go for a 6 mg bolus. If not, the rhythm is not reverted, you can go for 12 mg and 12 mg maximum of 30 mg. Beta blockers and calcium channel blockers can be used as a second line if there is a refractory, depends upon the patient's clinical scenario. Unstable patients, always cardioversion. So cardioversion is very, very important in unstable patients where the patient's cardiac output will be very less. The conducting systems will be very slow, so you have to pull up everything. So cardioversion helps everything. We'll see in later slides how cardioversion is done. So coming to the management of atrial flutter, the next most vulnerable rhythm, which we manage with again always a cardioversion is very, very important. Since the rate of atrial flutter will be enormous, it will be around 250, sometimes 280, so that the blood supply to the heart is almost getting deporized. So it's very important to do a cardioversion rather than going for a pharmacological drug. Okay. And refractory, always there is a radiofrequency catheter ablation therapy. You can do it for the patients. And again, atrial fibrillation, as you saw in the screen, you can give for amiodarone if it is a stable 150 mg IV bolus, or procainamide 20 mg per minute, maximum 17 mg per kg. And again, when it comes to an unstable, then always go for a cardioversion. So again, this is Wolff-Parkinson-White syndrome. This is again interventional regarding transverse catheter radioablation therapy, and drugs such as flicknide, amiodarone, and desperadine can be given. So this is a AHA ACLS overall protocol for tachycardia algorithm. Just for your thing put the same thing which we discussed, it has been put in a tabulation manner. So now coming to the management of wide complex tachycardias, the first and foremost is ventricular tachycardia. So here it is the amiodarone can give in 300 mg IV bolus. If needed, half of the dose, that is 150 milligram IV, can be repeated if it is refractory. And unstable, always cardioversion is the choice. And intervention, implantable cardiac defibrillator later on for the patient who is having a structural heart disease. Then coming to the torsades pointy, that is a polymorphic VT. The important drug along with your shock, magnesium sulfate is the drug of choice which has to be given in polymorphic VT, 2 mg IV. Isoflurane also can be started, and as I said, refractory, again go for implantable cardiac defibrillators. Ventricular fibrillation, which is a very, very, very important thing. We more come across in arrest situations, especially witness arrests in the hospital. Where they are to be saved very fast and rapidly. So you have to go for the AHA ACLS protocol. Always start your chest compressions and immediately get ready with your defibrillation, that is the DC shock. So if it is a biphasic, then go for 200 to 300 joules. If it is a monophasic, 360. Almost in all the centers, we have now only biphasic. Monophasic has been now gradually withdrawn. And the timing of the amiodarone, as per the AHA-ACLS protocol, only after the completion of third shock. Still there is a refractory VF. You have to give amiodarone. That is 300 mg IV bolus. The half of the dose, 150, can be repeated if needed. And alternatively, you can go for lidocaine, or refractory to amiodarone also, you can go for lidocaine. That is 1 to 1.5 mg, 1.5 kg IV bolus. But here the shock, DC shock is the main drug choice of treatment. So again, this is an AHA protocol for pulseless VT and VF. You start the CPR as well as once the defibrillations get ready, you are giving the first shock. Still, if it is refractory, you are going for the second shock. Then after the second shock, you are giving the first dose of epinephrine. Still refractory VF, you are going for your third shock. After the third shock, you are going to now give the antiarrhythmic drugs, amiodarone or lidocaine. So coming to the management of the heart blocks, usually the first degree heart block doesn't require any medications. Treat the symptoms, if it is symptomatic, like treat the cause. If you treat the cause, then automatically the first degree heart block will resolve. Coming to the second degree AV block, 1, that is type 1, exercises to obtain increased vagal tone or atropine can be given. Otherwise, coming to the second degree type 2, that is which occurs below the AV node, then atropine is not of use. Always pacing, especially if you have a transcutaneous pacing facility in your emergency room, then don't waste your time. Immediately start your transcutaneous pacing. Then later on you can go for the permanent pacing in case of complete heart block. So this is a small video about how to do a cardioversion. You have to first prepare yourself, prepare the patient, give him good amount of oxygenation, place a IV line, preferably in external jugular or if not peripheral line. Attach the electrodes which are on the monitor, and I'll track the electrodes. Look for the rhythm. Looks like an SVT. Keep all the emergency drugs nearby. Even the airway. Give a slow dose of sedation. Since you want to do a cardioversion, it will be painful for the patient. Always select the joules and charge and synchronize. Cardioversion, you have to synchronize. So before doing the cardioversion, before delivering the shock, you have to ensure that nobody is near to the patient, like I am clear, you are clear, everyone is clear. So ensure that, so that two things it happens. One is nobody, the surrounding people get the shock. The next thing is the most important one, the amount of shock which you have selected goes to the patient correctly. Otherwise, the amount which you have selected will not be delivered to the patient. That's very important. So this is a bradycardia protocol by ACLS, AHA ACLS. So whenever there is a stable, you can observe. When it is unstable and going for a complete heart block, think for transcutaneous spacing. So now we'll see a small there is a small video of transcutaneous spacing. All the pre-medications you have to be looking for. Get an oxygen. Keep ready with your emergency drugs. the intubating trace. First attach the monitor. Look for the rhythm. It's like a 3rd-degree AV block which needs a transcutaneous spacing. So now you remove the electrodes cable, attach the transcutaneous pad cable, attach the pads in the respective position. Switch on the pacer mode. Select demand mode. Then select the rate which you want to keep. Then the amps. Then start pacing with the lowest energy always. Then you can go up gradually. Once the pacing, the capturing beat occurs, then gradually you can increase the rate. So that the heart rate becomes stable, which is a very important thing. You can do it in your ER. Later on, if it is absolutely necessary, like if the heart block is due to any cause of a toxin or any other thing which can be treated, then you can start your treatment in the ER. If it is a structural heart disease, then the patient may require a PPI, permanent pacemaker, which can be done in the cath lab. So a small case scenario. This is a 54 years male presented to ER with compressive type of chest pain. Past 2 hours, also associated with vomiting of one episode. His BP was 90/60, heart rate was 75. It's a known DM. The ECG, when you take in the ER, shows this. Anybody can tell what is this ECG showing there? Yeah, it's an ST elevation in 2-3 AF, so it's an inferior wall MI. So you are ready to thrombolyze the patient. You are getting ready with the streptokinase or whatever thing, reticulase or whatever which you are familiar. So all of a sudden the monitor changes to this rhythm. So what you are going to do? What is this rhythm? It's a complete dial block, which more often we see in the inferior wall and RVMIs. So you need to go for a transcutaneous spacing immediately. So again, this is a second case. A 57-year-old male presents to emergency department with onset of chest pain, palpitation, sweating for an hour, BP of 90/60, heart rate of more than 140. The ECG shows this rhythm, which is an atrial fibrillation with rapid ventricular conduction. Since the patient is in an unstable condition, you need to go for an immediate cardioversion. Thank you very much. Thank you for the organizing committee for giving me the opportunity to speak with you. Thank you all.
The floor is open for discussion. Any doubts? Any doubts on ACLS protocol? Any arrhythmias, recognition? Thank you, Malay.
Thank you.
Another important thing during the ASV allergy, in my clinical practice, ASV allergy always load a 1 ml of adrenaline and mix with 4 cc of distilled water, keep it with you. Usually 99% of the time, 1 dose or maximum 2 dose of adrenaline mixture is more than enough. 1 ml plus 4 ml of distilled water, you give 1 cc of this mixture, IM, intramuscularly. And again, you have to sit with the patient when you are giving ASV trip, at least for 30 minutes. During the first 30 minutes, usually the allergy will occur. So always feel the pulse, sudden collapse can occur. So immediately 1 cc of adrenaline mixture is more than enough. Sudden collapse if you are having, immediately adrenaline, full dose of adrenaline has to be given. So maximum 99% of the time ASV allergy will be managed, very well managed with maximum 2 dose of the adrenaline mixture, 1 ml, after following that 1 ml, that's more than enough. 99%. So no need to stop ASV. Again you restart.
Thank you, sirs. May I now request the chairpersons to felicitate the speaker.
Now it's time to honor our station in charges who have worked hard to give us a simple yet profound demonstrations. I request our chairpersons to felicitate Dr. Raj Rajakali, Senior Resident in Emergency Medicine, SRM Medical College, Chennai; Dr. Madan Raja, Senior Consultant, Department of Emergency Medicine, Apollo Specialty Hospitals, Madurai; and Dr. Ganesh Adekalavan. Thank you, sir.
Thank you, sirs. I now request Dr. Muralidharan, sir, Associate Professor, to felicitate Dr. Palaniyappan, sir. I also request Dr. Palanikumaran, sir, Senior Assistant Professor of Department of Medicine, to felicitate Dr. S. Senthilkumaran, sir.
Now I request all our station in charges, Dr. R. Rajkali, Dr. Madan Rajan, Dr. Ganesh Adekalavan, Dr. Jude Vinod, Dr. A. Sharavanavelin, Dr. K. Muralidharan, sir, to join on the stage to take a group photo. I also request our HOD, sir, to join them. Sirs, we give a special thanks to Dr. Palaniyappan, sir, and Dr. S. Senthilkumaran, sir, to join us today.
May I take this opportunity to welcome the guest of honor for today's event, Dr. R. Murugayan sir, retired HOD and Professor of Medicine, to Medi CME 2022. I also welcome our beloved Dean, Professor Dr. A. Ratnavel sir, who has taken leave of his busy schedule to grace this occasion.
இல்லை அங்கே போகிறேன்.
நோய் நாடி நோய் முதல் நாடி அது தணிக்கும் வாய் நாடி வாய்ப்பச் செயல். மனநோயோ உடல் நோயோ உதிரம் கொட்டி தன் உணவர்களை மறைத்து உயிர் பிரியும் வேளையிலும் உயிர் கொண்டு பேணி உயிரை உடலிடம் மீண்டும் கொடுக்கும் உன்னத தொழில் மருத்துவம். அனைவருக்கும் வணக்கம். ஓய்வுதனை விரட்டி நோயதனை புரட்டி காலனையும் மிரட்டி காலத்தினை கூட்டி வாழ்வதனை காட்டி வீழ்பவனையும் மீட்டெடுப்பவரே மருத்துவர். இன்று அக்டோபர் 28 அரசு ராஜாஜி மருத்துவமனை மற்றும் ஏபிஐ மதுரை கிளை இணைந்து நடத்தும் பொது மருத்துவ தொடர்கல்வி மருத்துவம் நிகழ்ச்சியில் பங்களிக்க வந்த அனைவரையும் அரசு ராஜாஜி மருத்துவமனை பொது மருத்துவத்துறை சார்பாக வருக வருக என அன்போடு வரவேற்கிறோம்.
Moving forward, it's time to call upon and welcome our respected dignitaries, starting with our beloved Dean, Dr. A. Ratnavel sir, a forerunner to all the faculties, postgraduates and undergraduates of our prestigious institution. He was indeed set an example for all of us to follow by bringing out big changes with his charisma. Welcome you, sir. Next, I call upon the guest of honor for today's event, Dr. R. Murugayan sir, retired HOD and Professor of Medicine, an academician, teacher of teachers and a renowned clinician. Welcome you, sir.
Next, I welcome our respected Vice Principal in charge, Dr. Jayanti ma'am, to step onto the dais. I also call upon Dr. Dinagaran sir. He's leading nephrologist and renowned physician in Madurai.
Now I welcome Dr. Palaniappan sir, National API Vice President, whose energetic vibes are unmatched among all known by him. Welcome, sir. Sir, kindly step onto the dais. Now I welcome our medical superintendent, Dr. S. Vijayaraghavan sir, whose constant guidance and support has been invaluable for things big and small. Sir, kindly step onto the dais.
Next, I welcome our Deputy Medical Superintendent, Dr. Dharmaraj sir, to please step onto the dais. I also welcome Dr. Nadarajan sir, HOD, Department of Medicine, GRH. He's an icon among doctors in South Tamil Nadu and the name of the students in Madurai Medical College. His name is idolized among the medical brotherhood. We lovingly refer to him as the walking Harrison of our institution.
யாமறிந்த மொழிகளிலே தமிழ் மொழி போல் இனிதாவது எங்கும் காணோம் என்றார் பாரதி. தொன்று நிகழ்ந்தது அனைத்தும் உணர்ந்திடும் சூழ்களை வாணர்களும் இவள் என்று பிறந்தவள் என்றுணராத இயல்பினலாம் எங்கள் தாய் என்று தமிழ் தாயை போற்றி தமிழ் தாய் வாழ்த்திற்காக அனைவரும் எழுந்து நிற்போமாக.
நீராறும் கடலொடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ்வரத கண்டமிதில் தெக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு திரை முதலும் தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் வணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை வந்து வாழ்த்துதுமே வாழ்த்துதுமே
I also call upon Professor Dr. Bhagilakshmi ma'am, whose commendable innate capability of paying attention to the minutest of things in every single instance is just beyond words. I request you, ma'am, to please step onto the dais.
ஞாயிறும் திங்களும் ஞாலத்தின் ஒளி தீபங்கள், இரவின் ஆயிரம் கண்களாய் விளங்கும் நட்சத்திரங்கள், அதுபோல் தன்னை உருக்கி இருளை போக்கும் நிலை கொண்ட மென்மினிக்கள் தான் தீப ஒளி. இப்பொழுது குத்துவிளக்கை ஏற்றிட மரியாதைக்குரிய முதல்வர் அவர்கள், கௌரவ விருந்தினர் அவர்கள், பேராசிரியர் மருத்துவர் திரு பழனியப்பன் ஐயா அவர்கள், மருத்துவர் திரு தினகரன் ஐயா அவர்கள், பேராசிரியர் மருத்துவர் திருமதி ஜெயந்தி அம்மா அவர்களையும் பணிவுடன் அழைக்கிறேன்.
Now I invite Professor Dr. Natarajan Sir, HOD of Department of General Medicine, to come forward and deliver the welcome address, which will be followed by felicitation of the dignitaries.
A pleasant good morning, all of you. It is really a great privilege, honor, and what to say, to stand in front of you to deliver this welcome address on behalf of the Department of Medicine, which has got a very traditional, unique, antique value. Date back to 1950s when it was started. So such a department with a very good legacy. It is God's blessings, Lord's Meenakshi blessings given to me to stand in front of you to deliver this welcome address, prestigious welcome address on our CME. I like to welcome our beloved Dean, our close friend, Professor Ratnavel sir, who all of us know is one of the best dean ever our institution had. And I run out of words whenever I start talking about him. So such a gem of a man. I envy him because he is able to satisfy everyone, all sectors, students, public, patients, our teaching faculty, politicians, and who not. So really he has He's an excellent administrator, and our institution has seen an ocean of difference under his leadership. And as all of us know, he's not at all an armchair dean. He never sits for a long time in the chair. Always he go for rounds, and the word I used again and again, say on the spot dean. So wherever there is problem, he goes there. And such an excellent person, I think we are really blessed to have him. And he immediately accepted to inaugurate this function. And as each and every department feels, I also feel that he has got a soft corner for medicine department. And he is like a mother of our department or all our departments. A mother knows what a child needs. Even the child will not know what the child himself or herself needs. But he knows, he anticipates, and he has called me many a times. உனக்கு இது தேவைப்படும், அது தேவைப்படும், உடனே இன்டென்ட் போடு. So that such a far-sighted view for the benefit of the department, I think he is the first person who has done, and with his guidance and with his help, we have got IMCU. Most of us undergraduates also can see it's one of the state-of-art IMCU. Whatever you ask, whatever you don't ask also, he gives. So really we are blessed to have him. Sometimes I even used to think our institution or even Madurai is missing a very good cardiothoracic surgeon, because he was such an excellent surgeon doing transplant, cardiac transplant for the first time in South Tamil Nadu. But now I feel that if he had continued to be a cardiothoracic surgeon, he could have touched physically few hearts. But now being an administrator, he has touched all of our hearts. So I really, so this is, these words are from my and our hearts, sir. It is not from our lips. So our institution is blessed, and I think he will be going on even for a higher level like DME, and the whole state will be blessed by his administration. And I welcome you, sir, and you accepted our invitation magnanimously, immediately, without any hesitation, and you are right on time. That is more important, punctuality. So 12 minutes he is here, so we have to learn a lot. So I take this time to honor him with a small gift. Next, I extend my hearty welcome to my teacher, our teacher, and the teacher of teachers, Professor Murugan sir, who was